So now we are in part 2 of the chapter on lungs, chapter 11. This was where we finished part 1. We just talked about surfactant. We're still going to continue with ventilation, and that's going to be the topic that carries us through to the end of part 1, or sorry, end of part 2 of the lecture. So continuing with ventilation, we're going to get to this other topic. The term is elastance. It's the inverse of compliance, right? We said compliance was the stretchability of the lung tissue. Elastance is its ability to kind of bounce back from that. It's similar to elastic recoil. It's the ability to spring back after having been changed in size. It's due to these elastin fibers. Elastin, this diagram is from an old Gray's Anatomy book. If you can picture the alveoli, like all these little balls, and then they're covered in this protein called elastin. And as the name implies, it's stretchy. And so normal exhalation, we just relax the diaphragm, and the recoil of these elastin fibers act like a deflating balloon. They just, push the stuff out without muscular contraction. Here's the problem. There's a disease called emphysema, and it's directly related to these elastin fibers. But it's a little more complicated than that. All right, so the elastin fibers end up getting damaged by enzymes that are made by our own immune system, which seems crazy. The neutrophils and the macrophages, remember those are the phagocytic cells of our immune system. The neutrophils and the macrophages are there because there's some kind of inflammatory process going on. The elastin fibers are just collateral damage. They're not the target for the neutrophils and the macrophages, but because of this chronic inflammation that's in the area, the neutrophils and the macrophages have lots of enzymes that dissolve proteins, including the elastin fibers. Now, usually, that's not too much of a problem because we have this other enzyme that we make, the alpha-1 antiprotease. So it's anti-protein eating enzymes. The older name for it is alpha-1 antitrypsin. And I'm going to have you know that name too because of a genetic disorder. This protein, alpha-1 antitrypsin, alpha-1 antiprotease, it's produced by the liver. And yeah, the liver's not part of the lungs, but the liver, it makes a lot of our proteins. And so it's made in the liver, it gets out into the bloodstream, and it finds its way into the lungs. So the elastin fibers are being made just fine. The problem is the neutrophils and the macrophages are making stuff that's digesting these elastin fibers. And the mechanism that we have, alpha-1 antiprotease, that's supposed to protect us from this collateral damage, there's something wrong with it. Either it's being inhibited, the liver's making it, but its activity is being inhibited, or the liver's not making it right, in which case we have a deficiency. The most common cause of the inhibition is cigarette smoke. And so hugely important to encourage smoking cessation in any patient that has emphysema and is a smoker. You know that this is challenging, but this is the single biggest insult that's inhibiting the activity of this enzyme. So stop smoking, very important. Okay, then I mentioned it's not just inhibition, it could be deficiency. This protein just may not be being made. And it's a protein, the disorder is alpha-1 antitrypsin deficiency. The gene that codes for that protein is mutated. And patients who are homozygous recessive with that mutation, they're very likely to develop emphysema, even in the absence of cigarette smoking, not to mention how bad it would be with smoking. So these patients should be strongly discouraged from ever picking up the habit. And they might know that they have this genetic disorder if somebody in their family has it. All right. All right, so what happens? What's the big deal? If you've got plenty of compliance, what's the problem with that? The problem is we end up with loss of this recoil. We can't deflate the alveoli very effectively, and we end up losing. We had said the alveoli were like these clusters, like clusters of grapes, and we end up losing the septa in between them. And all that surface area that was used for gas exchange, that's being lost. These air spaces enlarge. We end up with air trapping. I'll talk about that in just a second. Yeah, so lung elasticity is lost. So when we expire, when we breathe out, the patient relaxes the diaphragm and the air can't get out easily. It requires greater force. There may be more muscles trying to push some of that air out. That's exhausting. This over on the right, this is the diagram from our textbook. And there's one thing that I like about it. In a well-functioning alveolus, there's recoil. The thing kind of shrinks back down. With someone with emphysema, those alveoli inflate, but they don't deflate very effectively. The way I think about this is, if you've ever had an old pair of socks or old underwear, this happens with swimsuits from one year to the next. Like, you can expand it to get it on, but then the elastic, it doesn't bounce back and it just kind of stays stretched. Like that is what's happening with these alveoli. Why it's a problem for breathing is this. The air is supposed to get in, but then the air gets trapped because of collapse of this wall. And so when the patient goes to breathe out, they don't empty the alveolus all the way. So the next time they breathe in, they're not getting lots and lots of fresh air. They're getting just a little bit of fresh air, and they've got all this leftover air that's in here. And as you might imagine, that's going to impact the ability to get oxygen into the blood. All right, we're going to shift gears just a little bit. Our textbook follows this format. So that's a disorder in which there's too much compliance, there's too much stretching and not enough bounce back. There's the opposite problem. These are restrictive diseases. These cause stiffness, so you can't inhale all the way. This happens due to an accumulation of connective tissue and fluid. It makes the lungs stiffer, for example. So again, this is called a restrictive lung disease as opposed to an obstructive lung disease. A best example of this is pulmonary fibrosis, in which connective tissue, stiff connective tissue is being put down, and the alveoli can't expand. On top of it, so yeah, the inhalation's impaired because of this collagen accumulation. But then on top of that, we have alveolar gas exchange is affected because that diffusion barrier, the space where the oxygen is supposed to pass and the carbon dioxide is supposed to pass in the other direction, that gets thicker. So it's harder to get the gases across. Continuing with these restrictive diseases, this is in acute conditions, something that would come on more suddenly. For example, pulmonary edema, severe generalized pneumonia, acute respiratory distress syndrome. And we addressed this briefly earlier when we talked about surfactant. In acute respiratory distress syndrome, the death of the type 2 cells reduce the production of surfactant. And surfactant, remember, was supposed to be helping us from having our alveoli collapse every time. And so in the absence of the surfactant, we get more alveolar collapse and it's harder to reinflate. So we reduce how much air can come in. And again, we're limiting how much gas exchange we can because of the thickened diffusion barrier. There's more stuff in between the air in the alveolus and the capillary. Continuing with ventilation, how we're going to assess airway resistance. So most of the airway resistance is in those airways that have the smooth muscle that can constrict down. So in the larger bronchi and the bronchioles, and it's influenced by the tone of the bronchial smooth muscle, how much bronchoconstriction is there. And so the test is a forced expiratory maneuver, where the patient's being asked to push out air. It's the most commonly used component of the pulmonary function test. This is something that you'll see done just in an outpatient setting, in a primary care outpatient setting. So it's subjects asked to inspire as much as possible and then blow out as fast and as hard as possible. And you're seeing how much air came out in the first second. And the success of this maneuver, it's limited by the compression or the collapse of some of the small airways. Let me show you a couple of graphs. So forced expiratory volume is what we're talking about. So the forced expiratory volume in the first second, that's usually the vast majority of the air that's in our lungs. We expect to get about 80% of the air that's in the lungs that we can get out. It's going to come out in the first second. Here is what happens with somebody with an obstructive lung disease. The forced expiratory volume in 1 second is tremendously reduced. That's as fast as they can get air out. And it's indicative that we're not getting good ventilation for this patient. So I'm going to try to explain why for these patients, this pursed lip breathing, blowing out through a smaller opening, why that helps. Remember, the problem is the air can get in okay. It's trying to get the air back out again. That's a problem. And so what the pursed lip breathing does is it increases the pressure, which you would think that's working against you. And it kind of is. It's working against the air that's trying to come out, but it's also working against this airway collapsing. And so the way I think about it is if you had a bunch of people in a location and they have to go through a doorway and the door opens in towards them, if the people run out and there's any kind of break in between the people and that door closes, the rest of the people are just stuck. Whereas if you slow everybody down, open that door, and then the people hold the door for each other, then you can get more of the people out. So it's a slower process, but it allows for more expiration, get more of the air out. And why that matters is because more and more of that air is becoming carbon dioxide and less of it is oxygen. And so we need to empty the alveoli or get as much out of the alveoli as possible before we replenish. All right. Now we're shifting to, we're still in ventilation, but we're shifting to a different topic. This has to do with bronchodilation, constriction. This diagram is representative of a smooth muscle cell in the bronchi. And I know that there's a very busy diagram. I'm going to point out a few things to you. First, let me just say, sympathetic nervous system stimulation, release of epinephrine from the adrenal glands. That, if you can see epi down here, and this is a beta-2 receptor. These, and I'll explain this momentarily, basically, when you stimulate beta-2 receptors, that's going to cause vasodilation. It's going to cause this muscle cell to relax. And so the bronchi can open. In contrast, when the parasympathetic division stimulates it, or you get inflammation with histamine, you get bronchoconstriction. Let me show you up here. Here's acetylcholine coming from parasympathetic division, vagus nerve. When that stimulates here, I'm going to point out something else. Here is the sarcoplasmic reticulum. That's something that all the muscle cells have. That's basically the smooth ER in a muscle cell, and its main job is storing calcium ions. So when acetylcholine comes in and stimulates that, that's going to cause calcium to be released. And you remember calcium is required for the actin and the myosin to be able to grab on to each other and contract. And so stimulation with acetylcholine or histamine, this is going to cause release of calcium ions and contraction of the muscle, bronchoconstriction. In contrast, and I'm not going to go into a lot of detail, I just want you to see this part, there's epinephrine, and this is inhibiting to this process. It's going to inhibit the contraction, even if the message is present. And that's why when somebody is having asthma, an asthma attack or some kind of allergic reaction, we can administer epinephrine and it'll counteract the other stimulation that's causing the bronchoconstriction. We can say, no, no, we were wrong. We don't want you to contract. We want you to relax. All right, so let's talk about asthma. This one often starts in childhood. Patients are dealing with this for decades. It's closely related to a type 1 hypersensitivity reaction. So basically it's an allergic reaction. When the patient is exposed to this allergen, I don't want to get into a huge amount of detail with this, but basically it activates some helper T cells that cause some B cells to switch up what they were doing. You know that some of the B cells can become plasma cells and they can make antibodies, immunoglobulins. Those B cells making IgG are caused to shift to making IgE, immunoglobulin E. And we know immunoglobulin E is most closely tied with either worm infections or allergic reactions. And what it does, IgE binds to the mast cells. Remember mast cells, they degranulate, releasing histamine, and the histamine is going to cause bronchoconstriction. So the patients present and they're wheezing. You can hear when they're when breathing in or breathing out, you can hear the wheezing. Subsequent exposure to the allergen makes things worse. There's leukotriene production during an acute attack. This acute attack, fortunately, is reversible. Obstruction and acute attack. So we treat it with bronchodilator. So something that's going to stimulate those beta-2 receptors and cause this to open up. A rescue inhaler. And it's a priority to get these patients breathing more easily. You may know that there's an acute asthma attack, and then sometimes 3 to 8 hours later, there's a late response. That's mediated by some other cells, the eosinophils, that are also implicated in allergic reactions. So anyway, if a patient has an acute asthma attack, they actually do need to be, you have to make sure that they can be observed or somebody can be with them 8 hours later to see, because that reaction can continue for 24 hours. And it's still, I mean, it's not like they were exposed again. It's just, this is a continuation of the same process. Persistence in adulthood. What triggers an asthma attack for a particular patient may change over time, but the fact that they had asthma as kids often is carried into adulthood. And it's weird stuff that will trigger an asthma attack. Aspirin for some people, exercise, cold air, exercising in cold air, having infections. What we end up with, the chronic problem is smooth muscle is a muscle, right? If you keep causing it to bronchodilate, if it keeps having to do this, it gets stronger, it hypertrophies, it gets bigger, which actually makes this airway wall thicker, which makes the space that the air has to move here, the space the air has to move is smaller because there's more muscle. Additionally, we end up with more mucus being produced, which is even more going to cut into the space we have for air to travel. The most important part of managing asthma is avoiding the thing that triggers the reaction. So avoid the things that the patient is allergic to. That has to be key. Additionally, in addition to avoiding those things that trigger, suppress the inflammation. This can be done with inhaled corticosteroids, leukotriene antagonists, leukotriene inhibitors, and then the bronchodilators. These are the beta agonist drugs, and the patient will need both long-term and short-term rescue inhaler medications to be able to manage the acute asthma attacks. All right, now we're going to talk about something that kind of sounds like asthma, but it's not asthma, although people who have asthma can be susceptible to developing this thing. So chronic obstructive pulmonary disease, or COPD. There's airway obstruction, and it's persistent. It's not reversible. That's how it's different. One of the ways it's different from asthma. The most common cause of COPD is chronic bronchitis. Let's go through what chronic bronchitis is, and then I'll tie this back to something else we already talked about. So how somebody gets diagnosed with chronic bronchitis. So bronchitis, inflammation of the airways chronically. There has to be a productive cough, some mucus being produced. That has to be going on for 3 months. And that has to have gone on for 2 consecutive years. With those conditions, that patient is diagnosed with chronic bronchitis. Unfortunately, the most common cause of chronic bronchitis is cigarette smoking. You may not be surprised to find that patients who are diagnosed with chronic bronchitis due to cigarette smoking are often also diagnosed with emphysema. And which disorder is causing which problem? It's part of the benefit of using this chronic obstructive pulmonary disease umbrella for both of those conditions. Because often, like I said, if the patient has emphysema, they're likely to develop chronic bronchitis and vice versa. All right, so what's going on? We've got leukocyte infiltration, smooth muscle hypertrophy like we saw in asthma, and we're making too much mucus. And the management strategies are similar to asthma, try to keep the inflammation down. One of the things that is visible, that you see in patients with COPD, and you see with patients with emphysema, is a barrel chest. So the patients inhale, but they have trouble with the exhalation. And so it actually starts to remodel the bones of the body. So you actually get this anterior, posterior, like from front to back, the patient becomes thicker, physically thicker. They may start showing signs of cyanosis, and they may spontaneously be doing this pursed lip breathing. So if you see somebody doing that, even without this diagnosis, that may be an indication that they have COPD. And then the final topic for part 2 of the lecture is still related to ventilation. And this disorder is known as obstructive sleep apnea. It's often associated with obesity. Let me explain why. So in a normal airway, air is coming in. This is a patient in a supine position. Air is coming in and out still, no problem. With obstructive sleep apnea, so apnea, I should define that. So PNEA, pnea, like pneumonia, that this is breathing, and ap, like the A, means not breathing. So something's interfering with the patient's breathing while they're asleep. And so what happens is you get kind of a collapse of this airway, so that a relaxation of the airway so that air can't push through here. And when I said it's associated with obesity, those of us who are carrying some more adipose tissue, there's more pressure around here, so it's easier to get a collapse. It's reversible because patient can change positions. Frequently, it's diagnosed using a sleep study, and the patient is wired up while they're sleeping to detect how often they stop breathing and sleep. It interrupts their sleep. Even if they don't wake up all the way, it rouses them out of sleep, and with the sympathetic nervous system surge of you are dying because you don't have any oxygen, and so people wake up gasping, or they don't wake up, but their partner wakes up. And some of the signs that somebody is suffering from sleep apnea is excessive daytime sleepiness. They'll tell you they slept for 8 hours or 9 hours and they're still exhausted. And it's because they're really not getting very quality sleep. And then because of the repeated sympathetic nervous system stimulation, it actually takes a toll on their heart. They have, the heart has to pump harder and faster because it doesn't, the blood is not oxygenated enough because they're not breathing for big parts of the minute, or of every minute. All right, so how it's managed with continuous positive airway pressure, or CPAP machines. For many of the patients, if they're able to start getting off some of the excess weight, that will also help to resolve this problem. Okay, and that is the end of part 2.